AI in health is a booming enterprise with enormous potential, but also enormous challenges. Much of the work of overcoming these challenges is in the hands of computer scientists and other engineers who have the technical expertise needed to create, improve, and refine these tools. But scholars in the humanities and the social sciences can also play a valuable role in the development of health AI. Here at Rice, Kirsten has been engaged for many years in writing about health humanities and AI ethics, whether questions of privacy or the role of the human element in clinical care. And there are many other scholars at universities around the country who are also doing work to apply the tools of the humanities to understand this transformative new technology. One of the areas of particular interest has been algorithmic bias. And I think this is the steepest uptick I have ever seen on the Google Ngram viewer. The term basically came out of nowhere and shot through the ceiling over the past decade. As best as I can tell, the term first came up not in medicine, but in other fields, looking at studies of hiring and also criminal justice, where people realized that these algorithmic tools were encoding various kinds of bias, for instance, into sentencing recommendations that were being given to judges. Algorithmic bias hits healthcare in 2019, especially with the work of Zaid Obermeyer, but now many others. Obermeyer's team analyzed a tool that tried to predict which patients in the ICU were most at risk of having a serious progression of their disease. They realized that the tool they were analyzing incorporated data on medical spending, and that turned out to be a problem because medical spending in this country is highly correlated with race and many other social variables, not simply medical acuity. And so they realized that this was a subtle way in which structural biases in society were getting incorporated into this clinical decision-making tool. Now, the fact that these algorithms might have bias shouldn't be a surprise to anyone. We all have biases and preferences. We have favorite foods, we have favorite music, we often make judgments about other people. Doctors have long been aware about various biases that impact medical decision-making. And one of the motives of the field of evidence-based medicine over the past several decades, starting when it launched in the 1970s, was to find ways to make medical decision-making more objective, often through the use of standardized diagnostic algorithms and treatment protocols. The hope was that if you could define clearly how you wanted physicians to behave, they would then follow those rules. Now, medical AI promises to be the next stage in that kind of evolution of evidence-based medicine. It can manage the largest medical data sets, whether from electronic medical records or from the insurance industry. It can use cutting-edge machine learning algorithms powered by neural networks that you've been hearing about for the past 2 days. And the hope is that this will be a set of tools that could help make medical decisions free of human bias. But it is clear that we are far from that so far. Bias can enter AI in many, many different ways, most often through training data, which often reflect the biases and structures of American society. There's a lot of work being done now to try to address this, but it remains very much a work in progress. One of the big challenges that I know has been discussed over the past 2 days here is this issue of transparency, interpretability, or explainability. Can we understand how AI tools produce their output? In the case of algorithmic bias, one of the questions is, can we know whether or not race or racism or related biases influenced the analysis? Often, too often, the answer is no. Many of these algorithms are black boxed, and it's very difficult to figure out exactly how they worked. And this is a hugely frustrating problem for scholars in the humanities and the social sciences. At our core, scholars in these fields work to interpret the thoughts and actions of individuals and societies. If the workings of these AI algorithms aren't knowable, then we can't interpret them. So my goal in this talk today is to demonstrate the value of transparency and interpretability through a case study of medical tools that are not AI tools, but instead were an earlier generation of diagnostic algorithms and risk calculators that were developed the old-fashioned way, using multivariate logistic regressions overseen by humans. Because of that, medical experts and scholars in the health humanities have been able to scrutinize and understand these tools. We can understand their origins, we can understand the values that are embedded in them, that drove their creators' actions, and that allows us, this understanding allows us, when appropriate, to criticize and push for reforms of how these tools function. As we invest in health AI, we face the risk of creating tools that cannot be scrutinized in the same way, and that could have dangerous consequences for both patients and doctors. So my goal here is to use a non-AI case study to demonstrate why it is important for AI tool creators to take seriously this question of transparency and interpretability. So doctors, shouldn't be a surprise, have paid attention to race in this country for centuries, specifically issues of race and medical diagnosis. For instance, when spirometers, a device used to measure lung function, were developed in the 19th century and imported to this country, researchers very quickly reported race-specific differences in average lung volumes and said you need to use these different standards to diagnose patients of different races. No one has yet written a thorough history of how and when race entered the many diagnostic algorithms that it had arrived in American healthcare. And that's work that remains to be done. But they certainly became more common, much more common in the 1990s and the early 2000s. And I think this reflects two different developments. One, as I mentioned earlier, was the proliferation of evidence-based medicine in this country in the 1970s and the 1980s, and the desire to come up with standardized algorithms to guide clinical judgment. And then also in the 1980s, growing concern about the problem of race-based health disparities in this country. In 1986, the federal government released its first major report on health disparities in this country, and that motivated a well-intentioned effort to take race into consideration in medical training and medical practice. And by the early 2000s, you start to see many different kinds of tools and algorithms that consider race, and you can find these in any area of medical practice: surgery, medicine, pediatrics, obstetrics. I'll talk about several examples. Now, it wasn't a huge issue in my own work. In addition to training as a historian, I trained as a psychiatrist. Psychiatrists have very few diagnostic tests, and I don't think any clinical algorithms. So I had missed this development as it was playing out in the 1990s and 2000s. And it first came to my attention through students I was working with in 2016. At that time, I was in charge of a new social science curriculum at Harvard Medical School. And this course was given a monopoly on students' time of January of first year. And we spent a lot of time in that course talking about the problem of race in American medicine. But then what happened is when students proceeded to the courses that followed, in pulmonary medicine, cardiology, nephrology, they paid very close attention to what their professors were saying about race in the classroom. And they often didn't like what they would hear. And they would come back to me, who they had known from the course in January, to debrief and try to understand what was going on. And so a group of them set out to analyze 3 tools that had race, in which race affected the interpretation of test results: pulmonary function tests, estimated glomerular filtration rate, and then various imaging tests and risk scores used for osteoporosis. They wanted to know where these tools came from and were the various kinds of adjustments warranted by the data that existed. And this wasn't just happening at Harvard Medical School. Within a few years, there were groups of students and residents at University of Washington and at UCSF that were asking very similar questions. The first published critiques of these race-based tools come out in 2019, one article about estimated glomerular filtration rate and one about obstetric risk calculator. And as the critiques started to come out, there was very quickly pushback against the critiques. And so you start to see a vigorous debate between the critics and the tool creators. And those debates quickly became extremely frustrating. They really got deep into the weeds of arcane details of the data sets on which these tools had been created, on the details of the regressions and the various coefficients that were figured into these calculators. And this was far beyond my expertise as either a psychiatrist or a historian. And the other thing that was going on in the field was that a lot of these tools had been created by prominent people in various medical specialties, and they were not amused that these medical students and residents were critiquing their judgment. So there was a big generational aspect to this conflict that it was brewing. it really wasn't a pleasant debate to be involved with. And so frustrated by the kind of trench warfare that had begun around these tools by 2019, I suggested to the students that we take a different approach. Instead of arguing about the technical details of each of these different tools, and again, there were scores of tools that you could have looked at, I said, why don't we step back and write a review that looks at a series of big picture questions and criticizes the assumptions that are widespread across all of the tools. Many of the tools relied on simplistic racial categories, often the distinction between whether a patient was black or not black, and nothing more than that. Many of the tools you could show by tracing the citations, could trace their roots back to really old ideas of scientific racism in 19th century American medicine. And then if you looked at how the tools operated, many of the tools, if used as directed by the tool creators, would focus medical resources on white patients. And it was a strange irony. As I said, many of these tools were created, I believe, as a progressive effort to address health disparities in this country. But by the time the tools were created and operationalized, many of them would have the opposite effect, directing healthcare resources towards white people in this country. So we wrote this up and published a critique in the New England Journal of Medicine. It came out in June 2020, in the midst of the first wave of the COVID pandemic and in the immediate aftermath of the murder of George Floyd. As a result of that, it got a lot more attention than we were expecting. But the important point here is we were able to do this work because these tools were transparent. We could look at exactly what they were doing and show what their consequences were, and then get the attention of an audience of people. And this approach worked well. As I said, the article got a lot of attention when it came out through allies who were usefully placed in Washington, D.C. at the time. It energized a national conversation leading to hearings in both the House and the Senate. The House Ways and Means Committee issued a request for information from various medical societies, asking them to explain and account for how they used race in their clinical algorithms. And then, because it was coming from the House Ways and Means Committee, then the most powerful committee in Congress, they got a 100% response rate. It turns out if the House Ways and Means Committee demanded information from medical societies knew that they had to provide it. There was this wonderful time when all of these reports were available on a US House website. They have all since been taken down. If anyone wants copies, just email me. I'd be happy to provide them. And so what I want to do is explain how these things worked, again, to show the importance of transparency as part of this critique and advocacy work. So the simplest one to explain was called the Stone score. And so the basic idea here is if a person comes to the emergency room complaining of pain in their flank, the question is this flank pain likely to be a kidney stone? And does this patient need to have a CAT scan as part of this workup? And so a team of emergency department physicians and urologists did a study in 2014. They looked at the records of over 1,000 patients who came to an emergency room complaining of flank pain. They coded the charts for 35 different variables that they thought might be relevant for this. And then they performed a multivariate regression to find out which variables were significantly associated with the outcome of actually having a kidney stone. And they focused on 5 variables: men, short duration of pain, the presence of nausea and vomiting, hematuria, having blood in your urine, and then having a non-black race. And they didn't really specify what exactly they meant by non-black race. They just left it at that. There were other variables that were also significant. So if this was a patient's first visit to an emergency room for this kind of pain, that was highly predictive that this was actually a kidney stone. But for a reason that I don't fully understand, they decided not to include that in their risk calculator. And so if you look at how this works, it's a simple scoring sheet. It was initially out of 13 points. And you could count out how many points the person got. So you get 2 points if you're a man, 3 points if it was acute pain, 3 points if you're not black, 2 points for nausea, vomiting, 3 points if you have blood in your urine. Adds up to a total of 13. Higher score meant higher risk. You were more likely to get a CAT scan. And one of the questions that should jump out at you is it really the case that being non-black is as great of a risk factor for having a kidney stone as having blood in your urine? Having blood in your urine is totally plausible. There's something wrong in your urinary system. You shouldn't have blood in your urine, but that was scored equivalently to being non-black. So when the American College of Emergency Physicians got the letter from Congress saying what's going on, they wrote up a very detailed analysis. And what they did is they went back to the tool creator, because this hadn't been created by the college itself. It had been created by a group of doctors at Yale. And they said, why did you create this tool that uses race in this way? And they said, look, we didn't do anything wrong. They did the regression, and race was one of the 5 variables that had the highest correlation with the outcome of actually having a kidney stone. And there had been other data from other studies showing that the incidence of kidney stones was higher in white people than black people. No one really knew why, but that had been reported. So it was plausible for them that it made sense to include race as part of the risk calculator. What the American College of Emergency Physicians did say was that if you used the calculator and just dropped the whole race question altogether, it worked just as well. So adding race did not improve the performance of the tool, but it was there. And then I assume under pressure from the American College, the original researchers went back and did a reanalysis of their original data and produced a tool that doesn't use race that works just as well. And this is now the one that's recommended to be in use. If you go to MD-Calc, this is the one you will find. Second case, the VBAC calculator. So for anyone who has had a cesarean section, subsequent pregnancies are at higher risk. The uterine incision doesn't heal as well as an unoperated on uterus, and so it creates a slightly increased risk of uterine rupture during a subsequent labor, which is an obstetrical catastrophe. And so for a long time, obstetricians in this country thought if you'd had a prior C-section, it would not be safe for you to undergo a subsequent trial of labor. So if you had a C-section, all subsequent pregnancies would be delivered by C-section. Over the late decades of the 20th century, people pushed back against that and demonstrated that actually many women could safely do a trial of labor after a prior C-section. And the question was, how can you predict which ones can do it safely and which ones are high risk? A totally reasonable question to ask. So in 2007, a group based in NIH, led by a Northwestern obstetrician, William Grobman, developed a calculator. As they describe in their initial report, they looked at a variety of variables: the age of the person, the pre-pregnancy body mass index, African American race, Hispanic race, whether they've had a prior vaginal delivery, whether they've had a prior vaginal labor after C-section, and whether there were other reasons for a C-section to be done. And they came up with a calculator, and you can see the coefficients there. The negative coefficients means that if you are black or Hispanic, you have a lower likelihood of a successful vaginal birth, and so they'd recommend a C-section for black or Hispanic women who are at high risk. There was no comment for why they thought race was a risk factor for bad outcomes for a trial of labor after C-section. And they also didn't say for people who identify as both black and Hispanic, would you apply both of those coefficients, or could you only apply one of the adverse coefficients? No comment about that, even though there are plenty of people in this country who do identify as both black and Hispanic. And so as the students dug into this, they realized something that was pretty interesting. The same group of researchers had previously published a study which showed more of their data. And if you go back in this data, it turns out there were a whole series of factors that were significantly associated with outcomes of a vaginal birth after C-section. Marital status, so married women were lower risk. Whether you were a smoker, people who smoked were at higher risk. And also your insurance status. If you had Medicaid, you were at higher risk of a bad outcome. But those 3 variables, marital status, smoking status, insurance status, were not included in the risk score, even though they were significant predictors. And again, the researchers didn't account for why they included some but not others. Presumably, they had some intuition of biological plausibility, thinking that maybe race was somehow more biologically plausible than marital status, insurance status, or cigarette status. The other thing that was interesting that we found was that the lead author, Grobman, had also been recruited by researchers in Canada to develop a risk score specifically for use in Canada. And the Canadian VBAC calculator does not use race or ethnicity. And the researchers simply said the ethnic and socioeconomic backgrounds of people are different in Canada and the United States. Somehow race was relevant in the United States. It was not relevant in Canada, which didn't make a whole lot of sense. And so I teamed up with one of our medical students and some obstetricians in Boston, and we wrote up a critique that highlighted these issues, these inconsistencies in how the tool was developed, the inconsistencies between the tools in different countries. We also noted that physicians in the United States have a very long history going back to the times of slavery, writing in unflattering ways about the differences between the pelvises of black women and white women. There's a long literature that describes the black pelvis as animalized or degraded. The white pelvis was seen as designed for giving birth. The black pelvis was designed for physical labor. And this is deeply embedded in the US obstetric literature and the various terms that are still used to characterize supposedly racial differences in the structure of the pelvis. And so we suggested that the reason that race was included and not the other social variables was somehow a reflection of this long tradition of scientific racism. Well, it turns out it was incredibly difficult to get this published. The suggestion that current practice was somehow tainted by the legacy of slavery was a hot subject both for our co-authors, who weren't sure if they wanted to put their names on that. And also what the journal seemed to do is, I think they sent the manuscript off to the tool creators to be reviewed, and we got a whole series of unkind reviews back from them. It took us a few tries. We got it published in 2019, got absolutely zero response until the critique was rescued from oblivion by a reporter for National Public Radio, Julia Simon, for whom I am eternally grateful. Health journalism is a terrific allied field of the health humanities that is more skillful at getting big audiences. She did an hour-long podcast on Reveal that got a whole lot of attention when it came out in June 2020, in the thick of the, so that's May 23rd, 2020, a few days before the murder of George Floyd. NIH very quickly felt the heat, reconvened the working group, and they immediately dropped race from the VBAC calculator. And so that was the fastest of the success stories. The one that has gotten the most attention is the case of the estimated glomerular filtration rate. And this one is complicated. Kidney failure is a huge problem for many patients in this country for a variety of reasons. And it's not easy to measure kidney function directly. There are ways you can do it, but it's a bit of a pain to do. And so physicians have long wanted ways to estimate kidney function from a more easily measured variable. And they realized that if you measured the serum creatinine, a byproduct of muscle metabolism, which is a routinely measured part of the basic chemistry panels, you can get a pretty good estimate of what glomerular filtration rate might be. And as these estimated GFRs came to be more widely used, it got embedded in a whole series of protocols. For instance, guiding decisions about whether to refer a patient to see a nephrologist, and guiding decisions about who should get listed, or who should be initiated on dialysis, or who should be listed for kidney transplant. And several large studies in the 1990s and early 2000s showed that the relationship between estimated GFR and true GFR seemed to differ by race. And so what researchers decided to do was add a series of coefficients to modify the calculation to account for this seemingly empirical difference between how black people and white people metabolized creatinine. And there were various rationales that were given for why this racial difference might exist. Early rationales asserted that black men have more muscle than white men, and so therefore their baseline serum creatinines are elevated. And you can trace those citations back through time, and they never come to a substantial research study that ever showed that black men were more muscular than white men. It was one of these things that was just simply asserted without a whole lot of data behind it. And then the more recent rationales would talk about genetic variations in different apolipoproteins, fixating on one that is more common in people of West African ancestry, and so therefore more common in African Americans in this country than white Americans, but still not seen in the majority of African Americans. The allele frequency is 15 to 30%, but that was seen as sufficient to change the medical recommendations for the entire class of African Americans, over 70% of whom did not have the risk allele. So again, it didn't make a whole lot of sense at the time. So the medical students, again, this is work they were doing as first-year medical students, wrote up a critique of the use of race in EGFR and shopped it around various hospitals in Boston. Now, we had a very sympathetic nephrologist at the Beth Israel Hospital, Melanie Honig, who became one of our collaborators. She was convinced by the students' work, and so she pushed the reform through. So the Beth Israel Hospital in Boston in 2017 was the first hospital in the country to drop race from EGFR. We made the same presentation at Massachusetts General Hospital. They were interested, but didn't want to make a change until we had done modeling studies of what impact would this change have on the care of their patients. Of course, no one had done a modeling study in 2010 when race was introduced into the algorithm. So there was an asymmetry, again, that was interesting to see. And again, as I mentioned earlier, activists around the country were doing this work, especially at UCSF and University of Washington. Amaka Nyanya published the first published critique of EGFR in JAMA in June 2019. That elicited a very angry response from other people in the field, including Neil Pao, who was a prominent internist at UCSF. The article that I did with the students at Harvard came out right before Pao's response was published. So we published in late June. His article came out in early July. This fueled a lot of tension amongst nephrologists around the country. And eventually, the National Kidney Foundation and the American Society of Nephrology organized a task force to look into this question of race in EGFR. It took them a year, but in 2021, late 2021, they issued their report recommending that race be dropped from the equations to calculate EGFR. They said there are a whole series of ways you can calculate it instead, and they reformulated the equations that now work as well, possibly better than the old equation did, and they don't take race into consideration. And then the fourth case I'll talk about is a slightly different tool. It's not a diagnostic test, but it's another one of these risk calculators. And so this goes back to work that started in the 1990s when the Society of Thoracic Surgery, which is mostly cardiac surgeons now, organized a cardiac surgery registry that has been based at Duke University since the mid-1990s. And this is probably the largest and best quality data set or specialty data set in any area of American medicine. The estimate is that they get data on about 95% of cardiac operations performed in this country, and there's nothing else close to that other than transplants in any other area of American medicine. So they have a nearly complete data set on American cardiac surgery. And so they wanted to produce a tool that calculated the risk of operative mortality or other complications after major cardiac operations. And you could go to the website, and it became quite clear if you poked around that if there was an option to enter the patient's race, they allowed you to use the classic categories of the US Census, 5 races, 2 ethnicities. And it became clear that there was a factor associated with being black that increased the risk of mortality. That was the only race for which you saw that effect. But unlike a lot of these other tools, STS had never published the inner workings of their calculator. They had written a lot about the calculator, but you couldn't figure out exactly how it worked. So we knew that race was doing something because you could see it in the output. Higher mortality rates if you identified someone as black and kept all the variables equal, but we didn't know exactly what. This was in the depths of COVID. My son was home on break. He's a very clever coder. I said, figure this out for me. So he just wrote a Python script that queried the calculator with thousands of patients and determined that the risk coefficient was 19%. And so that's what it was doing. So if you change the race to black, it would increase the mortality by 19%. And so we included that and wrote that up in our study. Now, the Society of Thoracic Surgeons was not happy with how we characterized their risk calculator. They said we misrepresented a few things. We had to make a change in the manuscript, but we did get it corrected to their satisfaction. And so then when STS received the request for information from House Ways and Means, they posted an incredibly detailed analysis of their calendar, of their calculator, much more detailed than anything they had published. So finally now with the response to the House, you could see exactly what was going on in this calculator, why they were doing what they had done. And they said this was simply an empirical question. They had, at this point, 25 years of data on cardiac surgery in this country. It was quite clear from their data that black men did indeed have higher operative mortality rates than white men. They had tried very hard working with social epidemiologists at Duke to figure out what factors associated with race might be driving this mortality. They included a neighborhood deprivation index, which was a score of socioeconomic status. And no matter how hard they tried, they couldn't find anything that fully accounted for the race signal. So they said, so there's something unspecified going on with this racial marker, and they felt an obligation to keep it in the score until they figured out what else was going on. And I think that's actually a defensible position for the most part. And so you can see they keep revising their calculator. It was most recently revised in April 2024, and it still includes that same 19% coefficient for operative mortality for black men having isolated or having coronary artery bypass grafting. I would still say, are these categories that they use, white and black, useful guides for medical decision making? I'd be happy to talk about that in the Q&A. So all of these four stories have a common element. Because they relied on regressions that were overseen by humans, they can be examined, they can be explained, and they can be interpreted. They can be transparent if their creators want them to be and publish the details of the calculations, or they can be made transparent if you're savvy with Python and can write the scripts to query the tools to figure out what they're doing. We could see that all of the tools, or nearly all of the tools, relied on this very simplistic notion of black versus non-black. We could see that the tools in general would lead to black people getting less care than white people. And those observations provided fodder for stories that we could tell. Even if we were just historians and medical students or residents, we could still tell stories that raised enough concerns to prompt medical experts to go back and take a second look at these tools and decide on their own whether they really felt that the race corrections were warranted or not. And when they did that, they most often decided that in fact they should not have been using race as they were. So just 2 weeks ago, the three of us published a follow-up study, a 5-year retrospective on our article from 2020. Of the 13 tools that we mentioned in 2020, 9 of those have been reconsidered officially by the responsible societies. And in 8 of those 9 cases, the reconsideration led to race being dropped. The decision was made by the experts that race should not have been there to begin with. The one exception was the Society of Thoracic Surgeons, as I explained, which keeps looking at this issue of race and keeps deciding to keep it in there. And then there were 4 tools where, as far as we can tell, the 3 oncology tools and one of the osteoporosis tools, the tool creators have not engaged with these debates. And so the race-corrected tools are still circulating. But even when the tools are formally revised by the relevant professional societies, that is not the end of the story. So as I'd said, NIH very quickly dropped race from the VBAC calculator, but most clinicians aren't aware of this change, and race-specific variations on the calculator still circulate online. In 2021, the Nephrology Task Force recommended dropping race from EGFR. But again, no one tracks this well, but as far as people can tell, only about 1/3 of hospitals in this country, there's over 6,000 hospitals, less than 1/3 have actually made the change. All the hospitals involved in kidney transplants have made the change because that was a policy decision made by the United Network of Organ Sharing. If you want to engage with kidney transplants, you cannot use a race-corrected EGFR, but that only affects the tertiary referral centers. Most hospitals in this country are still using the race-adjusted EGFR. And the reason is just money. To make the change, you have to reprogram your hospital's laboratory systems and your EMR, and a lot of hospitals just don't have the spare cash lying around to pay the programmers $100,000 to make this change. The one for pulmonary function tests is more complicated. The recommendation was made there to drop race from the interpretation of PFTs. That will be very hard to implement because it requires getting new software onto spirometers. And that means that your spirometers have to be a new enough version of the spirometer to be able to download the latest operating system. UCSF has been trying very hard to do this. Their contractor said would be happy to provide you with new spirometers so you can have the race-free patch, but it's going to cost them a lot of money. So last I heard, that had not happened yet. And then meanwhile, you won't be surprised to hear that there has been growing pushback against this kind of work. For instance, the change to EGFR has led to more African American patients getting transplants than before. For a variety of reasons, this country has a pretty fixed supply of kidneys for donation. And so that means if more black patients are getting kidneys, fewer white patients are getting kidneys. The changes in the pulmonary function test are predicted to have a similar effect. Fewer white patients will qualify for disability payments. More black patients will qualify for disability payments. Now, for the advocates, this seems like a wholly appropriate thing to do. Black people had been harmed for years in this country by having less access to valuable healthcare resources than white people. And so these advocacy reforms are trying to address that gap. But it has triggered a backlash. People say that woke medicine is now harming white people by denying them access to kidneys and disability payments. America First Legal, a law firm founded by Stephen Miller, has filed a brief in support of action by the Department of Justice to force disclosure of Biden-era documents about efforts to infuse equity into the healthcare system. In the accompanying press release, equity is described as an infection that has somehow contaminated medical decision-making. Now, I don't have a clear read on what the Trump administration really wants in all of this. It has released many statements saying that medicine should be colorblind, but it has opposed efforts to remove race from these tools since the push to remove them was motivated by a commitment to equity. And so it's stuck having two competing impulses, and I don't know where the dust is going to settle. My point here, however, is not the politics. It's that for these discussions to even take place, you have to be able to interpret the tools, to understand how they work, where they came from, why they do what they do. It is essential that AI tools are equally transparent, or are made equally transparent, so that engineers and humanists can scrutinize, and communities who are affected by these tools can make good decisions about the best ways to provide healthcare. Thank you.
Time for some questions, and there are microphones. Oh, one of these, okay. Let's see if this works. Okay. Questions?
Thank you. This is fascinating work. I have a question. So it seems like all of the examples you made, it was better to take out the race factor. And so I'm curious about your opinion, whether in general it would be always the case that you should take race not into consideration in those algorithms, or whether it could be actually valuable to have that. The other question I have is, you talked about the implementation gap, and so I was wondering, what is the best approach to address that? Because of course, that's an issue which needs to be addressed, and how can we overcome that challenge?
So in terms of the implementation gap, it really relies on hospital leadership who decide this is important for us to do, we're going to invest the resources to do it. I mean, you could say, $100,000 on the annual budget of the Texas Medical Center wouldn't even show up on the books. It's such a small number. Texas Medical Center is so huge that it would probably cost them more than $100,000 to do it. But one of the best examples has come from Michelle Morse, who's now Chief Medical Officer of the New York City Department of Health, and is nominally in charge of the public hospital system in New York City, the largest public hospital system in the country. And she has been involved in this advocacy from the outset. And even though she officially has authority over these hospitals, it has been extremely difficult, even in those places, for her to get these changes actually implemented, because in those hospitals, $100,000 really is a scarce commodity. And it's just simply a question of, do you have the resources and do you have the political will to mobilize those resources? Sometimes enforcement actions can do it. So when the United Network of Organ Sharing said all transplant centers must do this, all transplant centers did this. In early January, the Biden Department of Justice finally released long-awaited guidelines threatening civil rights investigations by the DOJ for hospitals that used unwarranted race adjustments. And so people thought that would finally solve the problem. That one of the first things the Trump administration did was pause the implementation of that. So it really depends on the broader politics. There have been lawsuits. I don't know the status of these. Vanderbilt, I know, is getting sued for racial discrimination. And if any of those pay out, that will get the attention of the medical centers. Now, in our 2020 article, we were very careful to pick algorithms which, if used as direction, would make health disparities worse, because those are the easiest to critique. Now, people have said, well, surely out there might be a tool that considers race that would have the opposite effect, that would address health disparities. And in principle, that's certainly true. You have to look very carefully at what the tools are actually doing to be convinced that's the case. But then you get back to the underlying question, are these race categories reasonable guides for scientific evidence-based medicine? Is it actually the fact that there are two types of humans, black humans and non-black humans, and all black humans should be treated one way, and all non-black humans should be treated a different way? And that's, if you think about it, that's just a totally preposterous assumption. And there are so many counterexamples. The easiest one, if you look at the case of Barack Obama, he self-identifies as black. Every hospital in this country would have race-corrected his EGFR. But as is widely known, he's half black. And he doesn't have any West African ancestry. His father was from Kenya. And so for the 6,000 hospitals that would have race-corrected his EGFR, they were implementing the one-drop rule, and they were showing confusion about East versus West Africa. That's just a medical error. Every hospital would have done it. And so the categories themselves are such bad proxies for human variation. I think that the dangers of using those tools outweigh the possible gains. If you really want to do something to help a disadvantaged population, you have to have a more precise definition of the risk group you're trying to help.
Can you hear me, sir? I'm coming to the AI. We talk about generalizability all the time whenever we are developing our data sets, right? Definitely there are differences among races. How do we go the balance between generalizability and personalization, especially with respect to AI model developments and implementation?
That's a really difficult problem. I was going to march back through my slides. One of my slides early on showed a book that was published by Andrew Lee, who's a historian and physician at University of Rochester. He wrote an article a couple years ago in the New England Journal of Medicine, just a short piece that looks at this question of generalizability or external validity, looking at one of the very first expert systems that was developed in the 1970s by researchers in Birmingham, and it was to analyze patients who were presenting with acute abdominal pain. And it worked really well at the hospital that it was developed in. And so then a hospital in Copenhagen said, we want to use the tool in Copenhagen. And it turned out the tool completely failed. Moving 200 miles totally changed the outputs of the tool. And they were trying to figure out what's going on. And it turns out there were a whole series of subtle differences between the hospital practices. At one of the hospitals, pelvic pain was considered part of the abdominal pain workup, and the other hospital was excluded. And so there were a whole series of differences like that that really confounded the generalizability of this tool from one hospital to another hospital. And that has been known, so that problem has been known for over 40 years now. And there's been a parallel problem with polygenic risk scores. If you develop them on one population, they work really well. Their external validity is quite poor. And so that's something that any creators of AI tools are going to have to be really careful about. Some people hope what you could do is that you could develop an approach to a clinical problem, train it on one hospital's data set, and it works. Then you take that approach to another hospital. Don't just import all of the coefficients, but retrain that approach on that other hospital's data set. And maybe that would work. That's obviously computationally complicated and time-consuming. That might be a better approach than just trying to move one trained model from one population to another.
Thank you so much. This is a captivating talk. My question was more about, you mentioned that in some of the research that you published, it was taken forwards by journalists who disseminated your findings, and that really pushed things through. Moving forward, do you think that this is a conversation that should be had for all of the publications that you publish in the future?
So in general, getting coverage of your research by thoughtful, skilled journalists, that's a big caveat, is a huge upgrade, and that will definitely increase the impact of your work. Our original article I was able to convince Gina Colada at the New York Times to write an article about it. She's a wonderful health journalist, did a terrific job. But there are plenty of not as good journalists out there who will misrepresent what you have done. It's very hard to get journalists' attention. So after the success of that, every time I publish something like this, I'll email Gina and say, how about it? Do you want to write another one? Anyway, and the article that we did, the 5-year follow-up, came out the same day that Health and Human Services released one of its reports, not the Tylenol autism one, but the one about a couple weeks ago about children's health. And every health journalist in the country was working on the RFK report, and they weren't interested in this. And so sometimes you can't get very far. It is what it is. There was one other thing I was going to say. And bringing attention, again, is good to disseminate the ideas, but then it also generates, the more attention you get, the more criticism you get. And you just have to have a very thick skin. So we always get letters complaining about this kind of stuff. Some of them are thoughtful and are worthy of consideration. Some of them are just sort of rants. But now it's very easy for people to rant, and they can rant online. And so I always prefer publicity, but it can be a really mixed bag. And again, and the reach of good health journalists is immense. And so if, and you have to invest the time, like when they call, and my response as a historian, they'll ask a question, I'll say, well, it's really complicated. I'll give a long answer. And then I know that they're going to distill it down to 10 seconds. And so there's a lot of risk in that as well.